arterial hypertension. So definition of pulmonary artery hypertension with the newest guideline from 6th World Symposium, it says when the patient has a mean pulmonary artery pressure of 20 mmHg at rest, which is revised from 25 mmHg. Pulmonary artery pressure was previously taken as 25 mmHg as the upper limit for diagnosing pulmonary hypertension. And the second is PVR, pulmonary vascular resistance. If it is greater than 2 Wood's units, if these two entities are present, then we can say the patient has a pulmonary arterial hypertension. So now the CTEPH, the chronic thromboembolic pulmonary hypertension, is a type of pulmonary hypertension. For that we need to know what is the classification of pulmonary hypertension. So this is the classification. It has 5 groups. The first group is the idiopathic, in which all sorts of causes of heritable associated drugs and toxins and HIV infection and all these are listed. Group 2 is mostly related to cardiac conditions, most probably the left side heart, in which heart failure with preserved ejection fraction, heart failure with reduced ejection fraction, valvular pathologies. Basically all the cardiac issues are kept in the group 2. All the lung associated issues are kept in group 3. Lung diseases like obstructive with restrictive, hypoventilation syndromes are kept in group 3. The topic we are discussing today is the group 4, which is chronic thromboembolic diseases. Group 5 is all the rare causes like hematologic disorders, systemic and metabolic disorders. In all of them, the hemodynamic parameters that are confirmed through right heart catheterization are the 3 main points, that are mean pulmonary artery pressure of more than 20, pulmonary artery wedge pressure of less than or equal to 15 mmHg, and PVR, pulmonary vascular resistance, of more than 2 Wood's unit. Previously, PVR was taken as a cutoff of 3 Wood's unit. Nowadays, after 2022 and 2018 guidelines, PVR is kept up to 2 Wood units and PAP is kept up to 20 mmHg.
So in group 2, pulmonary artery wedge pressure should be more than 15 or exactly 15?
For group 2, because it is due to cardiac diseases, it can be more than 50. But
क्यों नहीं के कदाच?
there
is no sign at all.
Yes, it can be more than 50 because in group 2 we are measuring the LA pressure. Due to changes in the LV and LA, the pulmonary artery wedge pressure increases. So for group 2 it has to be there. Now introduction and significance. Incidence is 1% of the population, whole world population suffers from pulmonary hypertension. It is a rare thing. Only 1% of the whole world population suffers from pulmonary arterial hypertension, out of which people suffering from group 4 is even lesser. So it is a serious and often underdiagnosed because of the diagnostic parameters. It has to go. A patient has to go through a right heart cath to get diagnosed with a group 4 PAH. So it is the cause is because of the unresolved blood clots in the pulmonary arteries. So historically it was considered as a fatal. Now with advances, it is considered as potentially treatable and curable. Again, early recognition and multidisciplinary management can always improve the diagnosis. So definition, as we saw, it belongs to group 4. Hemodynamic criteria, as we saw, it is the mean PAP of more than 20 mmHg, and pulmonary precapillary pressure should be around less than or equal to 50, with PVR of more than 2 Wood's units. And there is another criteria that patient should have gone through 3 months of anticoagulation, and even after that, if the patient presents with the PVR of more than 2 Wood's units, then we can classify them as group 4 PAH. So it is a natural history, quite simply explained, though it is more complex than that, because most of the patients that we see in having CTEPH usually have a history of acute PE in the past. They have undergone some pulmonary embolism, which is often treated or untreated or incompletely treated, that converts into CTEPH. That is more common history that is present. obviously there are more other causes involved to it, but it is a simple way to explain that. So those patients who have genetic or intrinsic variables, thrombotic tendencies, recurrent events, usually those patients undergo develop a CTEPH. Clinical presentation is having quite very common symptoms. Usually dyspnea, fatigue, exercise intolerance, chest pain, right ventricular heat. So early symptoms are usually dyspnea, fatigue, exhaustion, hemoptysis, palpitation and everything. Rare symptoms are exertional chest pain, which present late, hoarseness of voice due to dilatation of compression of left laryngeal nerve, shortness of breath, wheezing, cough. So these are very common symptoms which can be easily confused with other respiratory diseases. So this disease is often undiagnosed and incidence is often less because we are not able to get them to the perfect diagnosis. ECG changes are usually more of towards the right ventricular hypertrophy and right axis deviation, RV strain pattern, P pulmonale, right bundle branch block, ST depression and T wave inversion in the right precordial leads. These are the ECG changes that we usually see. X-ray changes are when the conditions are more due to the right atrial enlargement. We would see RA and RB being enlarged in the X-ray. Cardiac salute appears to be like a water bottle appearance. And when the changes are more due to left heart diseases, we see pleural effusions, early V lines, and signs of lung diseases due to COPD. We see flattening of diaphragm, hyperrespirancy. So these are the changes that we usually see in the X-rays. On echo findings, we will see enlarged right ventricle, base apex ratio will be changed, dilated RV, basal RV-LV ratio is more than 1.0. Flattening of the interventricular septum, that is because of the right ventricular occupying more space than usual. The interventricular septum that is curved in shape becomes a little flattened. RA size increases in the echo. TAPC is a parameter which is used, is less than 18 mm, and the newer parameter that is used is tricuspid TRV, tricuspid regurgitation velocity, that is more than 2.8 millimeters per second. So peak TRV velocity less than or equal to 2.8, 2.9 to 3.4 and more than 3.4. These help in diagnosis of patient having PH probability, if it would be higher or lower or intermediate. Accordingly, we can put them into classes. But the final diagnosis always depends after a right heart catheterization. Now the pathophysiology, why does a patient having acute PE or history of PE converts into CTEPH? After an acute PE in some patients, thrombi do not resolve fully. They become, in some of the patients, many of the patients they get resolved, but in some of the patients they get converted into organized fibrotic lesions that lead to further chronic thrombosis. And these lead to fibrin and collagen deposition in the pulmonary arteries, and that create the dead space in the pulmonary vasculatures, and leads to increased pulmonary vascular resistance. So basically CTEPH is a combination of macro and microvascular pathology in the pulmonary arteries. So this slide summarizes the causes leading to CTEPH. One of the causes definitely history of PE or recurrent PE, inflammatory bowel disease which causes chronic inflammation. History of splenectomy is present in some of the patients because of the blood disorders that leads to enlarged spleen. Then there is treatment of the patient with hypothyroidism, patient having superimposed infections, could be because of the pericardial leads, then malignancies and inflammation, variety of inflammation. Basically it is an inflammatory process which leads to the chronic thrombus formations. Now after the thrombus has formed, what happens, and in sometimes we also have abnormal PAECs, pulmonary artery endothelial cells and pulmonary artery smooth muscle cells. When they are also abnormal, they react abnormally to the inflammation, and inflammatory thrombosis occurs. There is impaired clot lysis, impaired angiogenesis, which leads to collagen and elastin deposition in the vasculature, the small vasculatures of the pulmonary arterial tree, and that leading to incomplete resolution and formation of CTEPH. Now, the normal heart picture is like this. The RV is very small in size, but in patients with CTEPH, the volume of RV increases. There is comparatively flattening of the interventricular septum. The interventricular septum is usually this curve, but it becomes flattened because of RV hypertrophy and volume overload.
So, when you said in the echo finding,
Yes,
that the IBS will be flattened, right?
Yes.
IBS will be flattened, right?
Yes.
So now, just with echo, if you need to rule out whether it is flattening because of RV overload or it is flattening because of RV pressure overload, volume overload or pressure overload, how will you differentiate?
Sir, in echo we have to also see other findings like there is increased pulmonary hypertension, pH is increased, RV strain pattern would be present in the echo. I mean, we will see right ventricular hypertrophy.
Just looking in the short axis view, how will you differentiate? You are doing nothing, just short axis view, right? Where you are seeing this particular picture, that there is flattening D-shaped IBS, right? But you need to tell whether because of volume overload or pressure overload.
It will have a D shape of ventricle there, this thing.
Ventricle, we are talking about IBS, right? So,
Yes. Thinned out, it would be thinned out than normal.
no. So, if you check it, I may be wrong, but if it is a volume overload,
Yes.
the flattening will be all throughout cardiac cycle.
Yes.
If it is a pressure overload just, then obviously left ventricular pressure will increase during systole,
Okay.
right? So at that time your D shape will become little circular.
Okay.
So looking at this particular finding, you can tell whether it is volume overload or pressure overload, right?
Yes.
Correct me if I am wrong.
Okay. So these will be the findings in the 2D echo. Now diagnosis, obviously through RHC we can confirm it. But when patient comes in the OPD having symptoms of fatigue on exertional dyspnea and everything, and on echo if we have ECG, echo and X-ray findings, if we have suspicion to go further, the next possible diagnosis we can do is on a VQ scan, ventilation perfusion scan. It is basically it uses inhaled radioactive gases for ventilation imaging and injected tracer for perfusion, and we check the mismatch in the inhaled part and the perfusion part which is given through the IV. If there is a significant mismatch present, then we can say there is a possibility of a perfusion defect due to pulmonary vasculature. So VQ scan is very sensitive. Then comes the CTPA. Obviously, it comes later in the diagnostic workup. First is the VQ scan. If VQ scan is positive, then we can definitely say that, not definitely, but very more likely that it does have a CTEPH. And then comes on the diagnostic workup CTPA, where we can diagnose which of the pulmonary vascularity is involved in the CTEPH part. And recent now SPECT, CT and VQ imaging are used. So it is considered as a preferred recommended screening test for CTEPH. How normal VQ would appear is this way, but when there is perfusion defect, it will appear like this. This is a normal perfusion where whole of the left lung is completely perfused. But when there is a perfusion defect, we will see some areas of hollow present. These are some slides showing the perfusion defects, which confirms that CTEPH is present or not. Next investigation comes as CTPA, where we insert a dye in the pulmonary vasculature to diagnose thinning of the pulmonary vasculature. That is seen here the sudden cutoff is present in the pulmonary artery. These are very subtle changes, but these are very well picked up by the radiologist and the operator who is doing the cath and the NGO. So there is thinning, sudden thinning out of the distal pulmonary vasculature. So it helps in delineating while if we go for a surgery, which area we have to focus on more. So this shows a normal CTPA and the less perfusion and this thing, thinning out of the pulmonary vascular just after origin in CTEPH patients. Now the survival part. Patients having CTEPH or high pulmonary artery pressure, the survival falls down significantly. If the CTEPH in mean arterial pressure is from 21 to 30, this is the survival period over the years. The downline is the years and this upper line is the survival percentage. Now we can see how the survival percentage falls down significantly when the PA pressure is more than 50. So modern treatment modalities, they focus on reducing the pulmonary artery pressure, how on all the facets how we can reduce the pulmonary artery pressure. First, the gold standard for the treatment is obviously pulmonary endarterectomy, in which we enter the pulmonary arteries, their branches up to segmental levels and try to remove the thrombus load how much it is possible. It is considered as a curative disease after PEA. The next upcoming part is balloon pulmonary angioplasty, in which the distal part of the vessels, the distal of the segmental vessels can be reached, and the balloon helps in dilatation, angioplasty of that area, and it is also used for inoperable cases. The newer drugs, Riosequat, it is a soluble guanyl cyclase stimulator, SGC pathway. We discussed about that pathway briefly. So it is used nowadays. It is the only drug which is FDA approved for treatment of CTEPH. Then there are multimodality in which we use all the three combining therapies. So first, pulmonary endarterectomy. Challenges of PEA. PEA is basically opening up the pulmonary arteries and the distal vasculature and removing the clots from them. So what challenges we face is, because of the chronic nature of the disease, the flow to the pulmonary artery is very narrowed down. So to get the blood supply to the lungs, naturally lot of collaterals develop. These collaterals hinder us while operating because there is a lot of blood coming out from the pulmonary arteries when we open them because of the high vascular and collateral flows. So how do we deal with such cases? We reduce the temperature of the patient to up to 20 degrees Celsius. When we reduce the temperature, obviously the requirement of the body reduces, blood flow reduces, and we take the patient to the circulatory arrest. In which we drain out all the blood of the body to the CPB machine, and patient is basically for a temporary period it is considered as a brain dead, because we cool down the temperature of the body up to 20 up to sometimes 18 degrees Celsius also, and we drain out whole body blood into the CPB machine, and then we open the pulmonary artery and remove the clots from inside. So and now by removing the clots, it is very challenging to find the dissection planes because it is stuck around the intimal layer of the pulmonary artery. So we have to dissect around the intimal layers and find out the dissection planes. Now as it is a chronic disease, the vessels are very thinned out. There are very much chances that we rupture the vessels, but with delicate and providing adequate time to the dissection part, we can prevent the rupture of that. And we are also dealing with the right heart dysfunction. Because of the pulmonary artery pressure, high pulmonary artery pressure, there is obviously a strain in the RV. RV is hypertrophied, it is weak, RV dysfunction is present. And obviously patients with such disease also have parenchymal lung disease.
What is the maximum time duration you can perform this particular?
For each part, like for the right and left, we start with the right side first. We have to give 20 minutes. For deep circulatory arrest, we give 20 minutes. We cool down the patient to the 20 degrees Celsius. Within 20 minutes, we have to remove all the clots from one side. Wow. Then we have to repair that part and again warm up and prepare for the circulatory arrest next time. So next time in the same sitting, patient warms up. Then again we cool it down and take the left pulmonary.
So is it done here at any time?
Sorry, sir.
First type of surgery is being done here.
We have not done here, but obviously they are performed regularly. But the thing is that these patients don't get picked up easily. There are a lot of missed out patients and a lot of diagnosis delays that occur before the patients get picked up. And when they come up, it is obviously a risky surgery. We have to counsel them. It carries a high mortality also. So, discussing with the patient and the relatives that obviously it is a curative part, but it carries a lot of mortality because of the vessels that are thinned out, because of the dissection planes that we have to find out. So, US FDA actually says that these surgeries should be performed according to their standards in a center where regularly around 50 to 55 cases are performed in a year. But that thing in India is unorganized sector. I mean, no cardiac center that I know. Then we obviously, after removing that, we have to check for any perfusion, punctures that occur in the pulmonary arteries. After checking that, we close it. Then we move to the other side. Then again, we have to go for a circulatory arrest and remove all the load that is present in the maximum part according to CV.
So no imaging during the procedure, right?
No, no imaging.
No imaging.
It is basically a planned procedure. We have to be very much sure which part of the area of vasculature we have to address first.
Can anyone in India say that I am an expert in this?
So there are a lot of people in the south, in Hyderabad, and because we had a recent lecture on this topic. Dr. Julius, I don't remember his full name, but he has done a lot of work in CTEPH. So he had come to take a lecture. But even in South,
it's done in South.
yes, yes. And all the centers in Ahmedabad and Baroda, they might be doing, but these are all the rough cases that we get at any point of time, and somehow we don't refuse or we counsel them appropriately, and they agree. It's like that. But accordingly, from the US FDA, which is a very structured pattern, they obviously say that a center was done 55 cases per year. So the steps are median sternotomy, we go on a CTB, we give antegrade cardioplegia, hypothermia is taken to 20 degrees Celsius and circulatory arrest. For cerebral protection, we cover the head with the ice pack is applied to the, it is more of the anesthetist part to cover the brain and with ice and to reach the EEG activity up to minimal level. So in centers where it is done regularly, they also have a EEG setup, where they intraoperatively check the brain silence completely, then we go ahead with the surgery. If it is not achieved, then we have to pull it further. So goals are obviously to relieve symptoms through reduced PAP, because it is the thing which helps in the survival part.
At least like बाकी से भी.
Sir, बहुत हो दीजिए. फटाफट करिए.
9:30 થઈ ગયા.
Yes, sir. So these are all the clots that we get. Mortality and morbidity, as we discussed, it has because of the pulmonary failure, reperfusion pulmonary edema often occurs. So in such cases, we keep the patients post-operatively really negative, around 1.5 to 2 liters.
So next time રાખવું છે કે પૂરું કરવું?
એટલે આ પીએ વાળું પૂરું કરી દઈએ.
હા.
એન્ડાર્ટેક્ટોમી
એના પછી તો સ્લાઇડ બગાવી છે.
ભગાવી નથી, મારે ભાગવું છે. નેક્સ્ટ ટાઈમ સાંભળજો.
નેક્સ્ટ ટાઈમ રાખીશું.
નો ડોન્ટ ભગાવો.
આ શાંતિથી પૂરો કરો પલ્મોનરી એન્ડાર્ટેક્ટોમી.
બસ આ પૂરું થઈ ગયું સર. આ તો એનો સર્વાઇવલ પાર્ટ છે. પછી કોન્ટ્રાઇન્ડિકેશન છે, ક્યારે નહીં કરવાની સર. Obstructive disease જ્યારે ઓછી હોય, pH is high but the obstructive disease is low, like we discussed in CTEPH. The involved pulmonary segments are less but pH is high, then obviously we have to go for medical disease. Liver failure decompensated.
અને એજ કઈ?
Age, sir, age is a relative contraindication. We have to assess the patient, how is his grade for surgery. If it is high risk, then we obviously delay and keep him on medical therapy. પછી મેડિકલ પાર્ટ છે સર આગળનો.
નેક્સ્ટ ટાઈમ રાખીશું.
નેક્સ્ટ ટાઈમ આટલું નિરાતે